everyone, and welcome. My name's Michael Moore. I'm a past president of the World Federation of Public Health Associations, and I'm the chair of the Global Policy Task Force on Immunisation. And today we're going to be discussing older adults vaccination and why is vaccination even more crucial in the most vulnerable of subgroups, because our focus is so often on infant immunisation, but today we're really looking forward to having a broad discussion about older people and the importance of immunisation there, and across the world, what's happening, how do we improve it, what are the things that we can do. And I'm very pleased, if I can go to the next slide, to introduce a number of participants. Kausar Afsana is a professor at the James P. Grant School of Public Health, BRAC University in Bangladesh, and she served BRAC for over 26 years as a director in the BRAC Health, Nutrition and Population program. She has been involved in quite a range of areas, with a background from an MD from Harvard and a PhD from Edith Cowan University in Australia, and has been honoured with many prestigious awards. We're very, very fortunate to have her, because she's played an important role at national and global levels in policy making across a wide range of issues. Also joining us is Dr. Vinod Shah. He's a MD and gastroenterologist and chairman of the Genoveva Foundation, which he founded in 1988. And he's been consultant on particularly healthy aging and other issues in a range of workshops with the UN, the World Health Organization, the Government of India, and of course, where he lives, Maharashtra, as well. He's the honorary physician to the governor of Maharashtra for over 30 years, a former member of the Steering and Planning Commission, vice president of Asia Pacific region of the International Federation on Aging. And this is just touches with all of these people. I'm just really touching on their skills. Dr. Rory Jansen McCree, originally a resource teacher of Maori language in New Zealand. He completed his medical training in Middlemore Hospital in South Auckland in 2000 and provided clinical teaching to Reo and Tukanga Maori programs for Maori health professionals throughout the country for several years. He's been chairman of the Te Atarangi Trust, which is a national Maori language organisation, as well as being involved in the Maori medical practitioners as well. And his main focus is on clinical leadership and looking at Maori equity as a general practitioner and clinical director. And we have with us also Dr. Ines Olivia Suto, who's an internal medicine specialist in infectious diseases Department of Tropical Medicine in the International Unit at Dr. Hebron University Hospital. Her master's in medicine and internal health at the London School of Hygiene and Tropical Medicine, and a PhD from the University of Copenhagen. She is also working with Dr. Nuria Serra del Cor, who graduated in medicine from the Autonomous University of Barcelona in Spain, also working in tropical medicine with qualifications from Antwerp University in Belgium, and a master's degree in epidemiology from Bahia Federal University in Brazil. Our team today is really very, very significant in terms of their skills and achievements, and I really like to acknowledge that. But while I'm acknowledging, I'd also like to acknowledge the support of the World Federation of Public Health Associations, GSK, and the University of Geneva in helping us put this webinar together. I'd like to start with my first question to Kausar Afsana. What is the current status of vaccination in Bangladesh, and who gets, in terms of older adults, who gets vaccinated and with what vaccines?
Thank you very much. I'm very much honored to be here today. For Bangladesh, actually, the government of Bangladesh has a very successful program, immunization program for the children, and that attained actually a good coverage for the 10 vaccine preventable diseases. But the government national policy has also incorporated an adult immunization in 2013, but still, it has not started as yet on the ground, except the COVID. We'll talk about this afterward. In 2021, government across the country vaccinated at some point only with adolescent girls, 11 to 18 years old, with MR vaccine, that's the measles and rubella, and along with the tetanus toxoid vaccine. So for the adult vaccine, in fact, in Bangladesh is the tetanus toxoid vaccine, which is given during pregnancy. And if during pregnancy, the women found that they're not vaccinated, if the adolescent girls get vaccinated, then during pregnancy, they don't get TT. So TT coverage is really good. And Bangladesh government also initiated intervention in some areas. It's on diphtheria and tetanus vaccine together, TD, for the adolescent girls, following the same schedule. And Bangladesh government also piloted human papilloma virus vaccine in 2016 and 17. But still we are waiting that the vaccination probably will be rolling out, and that's the situation at this moment. But as I said, the policy document you can see, but in implementation, we don't see in the field on the ground as yet.
Yeah, thanks, Kesa. And I'm just going to go to Dr. Vinod Shah and ask how this compares to what's happening in India and particularly Maharashtra from where you are.
As such, in India, we have now more than 62% of the adults are vaccinated. Our mass vaccination program is still going on. Most of the people, they got first and second dose and now also booster dose, and it has affected very nicely, so that still we are seeing patients of COVID in India and even Maharashtra. Even yesterday, I should say that more than 2,000 patients were detected positive, but still the complications are very less. Hardly 1 or 2 are here and there, some are admitted, and it's all because of this vaccination, which is very effective. Initially, we had a lot of problem in Maharashtra in starting the vaccination, because availability of the vaccine was through Serum Institute only, and then other companies came forward, and like Bharat Biotech. And so we initially had Covishield vaccine, and then we had this Covaxin vaccine. And then there are now so many types of vaccines that have come. And in Pune city, also almost 70% of the people are totally vaccinated. As such, adults are about 65% adults are vaccinated. I think whatever aim of our Prime Minister, we are just fulfilling, and the complications, and because when there was no vaccine, we know what type of havoc this COVID has made, even in India. Up till now, we are having more than 5 lakhs deaths, means 0.5 million deaths in India due to this, and almost the number of our population is 1.38 billion. So the number of patients were so many, that almost more than 43 millions they were affected due to COVID. So I think with these vaccination programs, Now we are much safe.
Vinod, I wonder if I can interrupt and ask you, has that been a springboard for older population for other vaccines as well?
Yeah, as such, government is not having any policy to give other adult vaccinations. For example, this hepatitis B vaccine or Shigella or herpes vaccine or SARS, that is H1N1, or even pneumococcal vaccine. They don't have policy, but in our ministry, they have suggested that those who can afford, they should take it, because affordability is the main problem. Government cannot finance all this. Occasionally, government gives some finance for H1N1, but not for other pneumococcal and other vaccines. And now elder people are now aware. And after COVID, they are more aware. They come to us and they ask us, sir, shall I take this pneumococcal also? Shall I take this H1B1, H1B1 every N1 every year? And they are taking. So those who can afford, they are taking. Government is giving free H1N1 vaccination to small group of people. Even in Pune itself, we have given to 2,000 seniors in Pune totally free H1N1. But as such, even this herpes also, people are not that aware. What the problem is regarding awareness. But now after COVID vaccine, looking at the effect of COVID on the people, and as they have survived now, they are now asking for the vaccination, but government is not having a policy. They purchase the vaccine and or government gives some subsidy, but not totally free.
So we are hoping that governments will begin to realise the importance of productivity in dealing with other vaccines as well. I'll come back to you, but I'd like to go to Dr. Rawiri McCree-Jansen. And Rawiri, you've got a really specific issue. We know that Indigenous people worldwide, their health outcomes are invariably at a lower level than that of non-Indigenous people. Would you like to just share with us how vaccination works for older Maori people?
Yeah, so in Aotearoa, New Zealand, the vaccination program was rolled out according to age, and we were advocating that there should have been an ethnicity adjuster. The Indigenous population should have been able to receive the vaccination at a younger age. And so some of the science suggests that it would be 20 years earlier. So the non-Indigenous white people of New Zealand would have a similar risk from COVID disease that a Indigenous person 21 years younger would have. So we battled quite hard on that. We didn't get there, but we did do a lot of work to make sure that we had a very, very effective vaccination rollout for the Indigenous population. And so we end up currently with Māori over the age of 65, 89% fully vaccinated, so boosted. So a good result, a lot of work to get to that point. And you know, as we roll further into it with, you know, going down into the younger age groups, we can see that the differential access to the vaccination program is still causing us some exposure to harm.
Yeah, and look, there was a similar situation for Indigenous people in Australia, but an adjustment was made to improve their access to vaccination, recognising them as a vulnerable group. Which reminds me, I normally acknowledge Indigenous people and pay my respects to their elders past and present, because I normally live on the land of the Ngunnawal people. And so I would like to extend that into all Indigenous people internationally. If I can do that on your behalf, Rawiri, that would be appreciated. And if you'd like to
thank you. I appreciate that, Michael. Nā mihi kia koutou, nā iwi take huri no te ao. Yeah, so acknowledge the Indigenous people who have joined us from all the different jurisdictions. Michael, it was interesting to us that Australia did make a principled decision to have an age adjuster for the Indigenous population in terms of vaccination rollout. And it was certainly something that activated us. You know, Australia was leading that. And we were really disappointed that our own government didn't follow suit. But yeah, appreciate your comments, Michael.
And look, we need to think about this, not just with regard to COVID vaccination, but we need to be thinking about whether it's shingles or pneumococcal, whatever, varicella. We need to actually be thinking in terms of how we use this as a springboard to persuade governments of the importance of vaccine. And I think that's a good transition to Ines and to invite you now to answer those same questions about the current state of vaccination in older adults in Spain and who gets vaccinated, which vaccines, and you might take to the next step as well. And are there subgroups that we've already touched on? I will just, before I go to you, Ines, I do note that there is a question asking about the fourth dose and should that be necessary for medical workers. And the question comes from Professor Meng-Chi Lee from the Taiwan Association of Public Health. If you would like to throw an answer in on that as well, and otherwise we'll come back to that. Over to you, Ines.
Okay, thank you to you. Thank you very much for giving us the opportunity to be here. We are part of the front line. We are the doctors who see the most the migrants and in different status. Okay, first we can talk about we belong to the infectious disease department of the big hospital in Catalonia. Here the health system is free, vaccination is free, all the consultations is free of charge, and this is an important issue for the access for this population. But we face different challenges. One of the most important is that we work with migrant people, but in all the status, refugee, asylum seekers, and also illegal immigrants, okay? And then in general, we offer the serological status before vaccination. Normally we do that. We offer to do the blood test first and after the vaccination. And in general, when we do that, the vaccination status are quite different because we have like a big picture of the migrants from the different part of the world. From Sub-Saharan Africa, most of them depends of the age, but we can, in the last study that we did last year, that 85% were only positive for measles, and it was something that is quite important for us, okay? Also, regardless hepatitis B depends of the coverage, depends of which part of the world we are talking about. Then in general, the vaccination status is regular. We can say that it is different really much if we are talking from Asia or we are talking from Latin American immigrants, or if we are talking from Africa, not only Maghreb. I think it's a really heterogeneous population, and we cannot only talk about one and say, okay, because we have to talk closely. In regard to the question about if it's needed, the fourth doses is something that we want the answer because we don't know, okay? So far, we have a really good coverage of the health professionals, and in some way, we are prompt to do that, but we don't know if it's necessary so far. We think that there are a lot of studies going on, and the answer we will have in the coming months. Okay.
Thank you. I do know in Australia that the recommendation is that health workers, when the time comes, and those who are vulnerable, do have the fourth dose. I think it's similar in New Zealand. You may correct me, Rhea, it is similar in New Zealand. Kausar, can you tell us about, let's come back to you, about that fourth dose in Bangladesh, but also let's go to COVID vaccine, because you didn't talk that much about COVID vaccine and how that has had a broader influence within Bangladesh as well?
Thank you. Bangladesh actually started COVID-19 vaccine in last year, 2021 in February. And then you probably know that, Bangladesh was actually procuring vaccine from India, the Serum Institute, but, there was some problem at that time, and, vaccine demand was so high within the country, so they couldn't supply it to Bangladesh. So Bangladesh at the beginning actually suffered, even till I think September, October in 2021, but then Bangladesh actually started going up, and we got vaccine from COVAX, and also from Serum Institute we got vaccine. We got vaccine from China, Sinopharm and Sinovac. And at this moment, Bangladesh actually for COVID, first and second dose went up. First dose is above close to 80%, and second dose is above 70%. And third dose, that booster is going on, and that is actually 18 or 19%. And but as I know that question is coming for the older population, and you probably know that for this part of the world, especially Bangladesh, our young population is much higher. So above 67% population. So what I have seen from the data, and that was not published, but that from that, I have seen that the vaccine above 80 years old, sometimes it's a little less. And then, one is people are scared that the older people might have, other problems. So that is one of the reasons. And secondly, I also feel that the way the vaccine is given, that the older people are also expected to come to the center for vaccination. There is no arrangement for the older one to have the vaccine at home. That could be another reason that why the vaccine level of above 80 is less. But in general, in Bangladesh, actually is quite successful for COVID-19 vaccine.
It raises a really important question. I'll go to you, Vinod, and then to you, Ruwiri, about how you reach out to older people, the extent to which vaccines for older people are funded. Vinod, you already shared that information, but it doesn't hurt to reinforce. And what would you like to see as a method of ensuring a much broader vaccination, not just for COVID, but across the spectrum where appropriate older vaccinations apply? So to you first, Vinod, and then to Ruwiri.
Actually, India being the vast country, and to reach the vaccine to the remote places was a challenge to the government and all health centers. But ultimately, we could achieve with this a lot of donations from the big companies under CSR, and our Prime Minister appealed for that, and we could get many vehicles and good transport of vaccine at the root level, at grassroots level also. But still there was a problem that people were afraid of taking the vaccine because they were not aware that what is going to happen. Is there any reaction? They are afraid of their even death, that after taking vaccine, I might die also. So because of that, we had to counsel the people and even the elderly people. And we are successful in making the people confident that they will not be any problem. But still, I must say in Pune city also, we have seen few patients after taking vaccine, they had a lot of problems, maybe because of vascular thrombotic attacks, and one or two even died after taking vaccine. So because of that, people were very much afraid. Actually, during starting this vaccination in our city and Pune division in Maharashtra, government asked me to take first vaccine, so that I am being now 75 completed. They said that if you take, and as you are, people know you all over, so if you take, many more will take. And so I am the first person to have vaccinated myself in January 21. So we have multiple barriers. Transport is a much more problem, but then ultimately the people, those who are handicapped, say those who are having hearing problems and they are having paralytics, they couldn't come to the center, and ultimately government has to take the decision that we should go to their house and give the vaccination. So for blind people, and then that government also did, and even there was a transport mechanism there. Even our foundations vehicles were working a lot on them to bring the patients from remote places to the vaccination center. Actually, there was a lot of barriers. As I told you, that major is the fear of death. But along with that, people were not sure about the vaccine efficiency. So when they heard that after taking vaccine, after 6 months, the severity of the disease has come down, they started, the more and more people and elderly people started taking vaccine. So the fear is the one of the barrier in this, and that also will we try to remove that fear.
You know, it's been very interesting that we hear a number of those barriers that you're talking about, Dr. Shah, that it's not just availability of vaccine, that has certainly been one of the barriers, but particularly for vulnerable groups, about how do you get to them? How do we bring them into the, whether it's migrant groups, how do we bring them to hospitals? How do we reach out to them? And each of you has raised that. I wonder how that applies in Maori population in New Zealand. Perhaps even Maori and Pacific populations, actually.
I wanted to go to your earlier question, and you'll have to remind me to come back to this one, but in thinking about the vaccination rollout here in Aotearoa, so we didn't get started as early as Bangladesh. We didn't get started as early as India. We had a really total lockdown. We're an island nation, so we had very limited cases coming into the country, and an early decision was made to go with the Pfizer vaccine. And so it's Pfizer all the way here until much later, when we have added in the AstraZeneca, the Janssen and the Novavax very recently. But Pfizer all the way created a whole lot of delays for us to get started. So we had to get the super cold fridges. In the early days of rolling out Pfizer, it could only be out of super cold for a short period of time. Everything was how many hours it was out, 120 hours. Every vial had to be used within that time. And so that created a concentration of sites where you could deliver the vaccination. And so the urban centres were privileged and the rural centres were left in a catch-up mode, really. And then we had all these really interesting battles about whether or not we could do drive-through vaccinations. And there was an interesting contestation of ideas as to whether or not drive-through vaccinations would be accepted by the Māori population. And we advocated strongly, Māori doctors advocated and said, yes, it is very acceptable. And we know this from the first year of the COVID outbreak when we were under lockdowns and we were doing drive-through vaccinations of flu. And so we knew that it was highly acceptable. You could have a family come in a car, or you could have a van full of people rock on up to a clinic and get their flu vaccination. So we were very confident that drive-through vaccination was going to work for Māori populations. And as we're going through that, then over time, it became easier to have the Pfizer vaccine. You know, we were released from some of the strict ways of managing the vaccine itself, and we were able to travel it over better distances. And so the two things rolled out together. So a more amenable way of doing the vaccinations meant that we could reach further into rural populations. Over time, we started doing more and more community vaccination pop-up centres. We then did, sort of camper vans and vans driving out into urban settings all over the cities, into rural settings all over the country to get that vaccination really lifted up. And so it effectively took us about 8 months to get into a really good position with the vaccination. But we've learned a lot about acceptability in that. It's been a relentless march to get to a place where we're virtually 90% vaccinated and boosted for our older population. So a lot of learnings along the way.
So coming back to the original question that I was also exploring, and you've sort of touched on it, is how do we now, what lessons have we got that we can learn to reach out to vulnerable populations? You mentioned rural in particular, but perhaps you could give us an insight into what you think might be some of the lessons.
Yeah, I think Vinod's touched on access issues, and I think those are really important to address them. And it won't just be access to primary health services, because we've learned that you can create pop-up health centres. I think we've got to think about access in terms of access to trusted health information and trusted health professionals. So it's got to come from the community. The community must trust in those people. So access will have an element of distance and trust and cost. Again, in Aotearoa, we were able to have the vaccination program free, and it didn't have a direct cost, but it certainly had a cost in terms of time off work or traveling to a clinic. It certainly required a lot more trust. We were exposed to a lot of the misinformation and disinformation because we came to this vaccination program later than we should have. If the Indigenous population had been first in that first vaccination rollout, and we'd had good information by trusted Māori health professionals, we would have had a much better run at it. But over time, we got to the right place.
It is interesting that you draw attention to the not only trusted health professionals, but trusted health professionals within a cultural group. And I think that's really interesting. How did you find that, Dr. Ines Oliveira Soluto? Did you also find that when you were dealing with migrant groups and refugees and so on? Can you share how that was?
Hello. Yeah, for us, it's important that we have a cultural competence services in the way that we have community health workers. We have people from the community, and they help us to reach the community and to make the bridge between us and them. For us, it's really important to have open hours, a schedule really long, because sometimes it's quite difficult. For us, related with the COVID vaccine, we were one of the point of vaccination for vulnerable people last year in summer. It was something quite challenging, because at that point we were vaccinated with Janssen, and you know that the vial is 5 doses. And then there was a time that we cannot waste vaccines. And then for us, we have to make 5 appointments to open the vial. And it was something really challenging for us. But the acceptance of the people was high. I think that if you spend the time explaining why and the reasons, I think our reality was good. Okay, but it's important to have these community health workers to make the journey with the community.
Thanks very much. I'm going to actually go to the most recent 2 questions that have come up from our audience. And the first one is about the introduction of adult immunisation under national immunisation programs, because there's a lot of discussion around cost effectiveness. And I think that that is an important question, but I think it should also take into account productivity and productivity outcomes when you actually talk about cost effectiveness. Because has that been a matter of discussion within Bangladesh and your surrounding countries?
Yes, thank you. Because this is very important question for all of us, and especially the issues of vaccination for the adults. One of the things we are struggling at this moment because Bangladesh is going to the graduation country that where Gavi is actually reducing the amount of money they are giving. So Bangladesh government is giving around 40% or maybe a little bit more than 40% of fund for the vaccination, and that vaccine money is actually going for the children's vaccination. COVID-19 vaccination is free in Bangladesh, and that's also taken care of by the government, but that is a separate budget that is not coming to in this budget. So as you say, the cost effectiveness. So that's the dilemma, that why Bangladesh is still being slow to introduce that adult vaccines. One of the reasons is that you need to also, think about the child vaccination, because after 2028, the whole the budget needed for vaccines should be borne by the government of Bangladesh, because vaccine is free in the country, but there are private sectors. I could come back to that, but that's one of the reasons that why this, cost effectiveness and the local production, that's one of the issues also being discussed in the country is going on, that how if you could start producing within the country, maybe the cost will go down. But we know that, especially during COVID-19, we learned that how the raw materials coming from different parts of the world also affect this vaccine production. So we need to know better that how could you develop a good, global partnership. We know that, COVAX, helped a lot, but we could understand, sorry to say that, especially during this, when the vaccine started, and how the countries which are, big countries producing vaccine, the way they behave, as if, if you can just keep it in your own country and you protect your own people, that means that, you can, that's the solution. But we can understand from COVID-19 that, if you really would like to save the world, we have to actually protect each and every one by vaccination. So that's the lessons we learned from COVID. I hope that that will continue to be a global agenda and also for the country agenda in future.
Kauthar, I think you make one of the most important points of this discussion. I'll just go to Vinod. I do notice that we've been joined there, Ines, and I presume it's your colleague, Dr. Nuria Sarah Delcourt, and I'm very pleased that you've been able to join us. I did introduce you earlier, but before I go to Vinod, I'll give you a chance to make any comment from what you've heard so far.
So thanks to introduce me, and I'm sorry to be late to the meeting, but I think that Ines, I'm sure that she did it great. So just about the cost effectiveness, to our knowledge, what we know is that for hepatitis B and in MMR, it was already proved that it's cost effective to do the vaccination. And so this is what we know, but not, and we are convinced about that. Nothing else to add.
And that does answer one of our previous questions. So that's that I was getting to, and I think that's right. And so I'm very keen about this discussion around cost effectiveness, not only in terms of return on initial investment in preventing people being sick, but how it works in terms of the whole economy as well. And I wonder, Vinod, if I said I was coming to you, if you can share your experience in how government looks at it within Maharashtra state as well as India as a whole.
The cost of vaccines in India was high, but slowly they reduced the cost. But fortunately, government has started giving vaccination totally free of charge. So they didn't charge anything, and except those people who can affordable, they were requested to purchase the vaccine. But otherwise, it was not a tax on the beneficiary. Government could make this arrangement through a lot of CSR funds and also through their health departments. So it was a challenge to give free vaccine to so many things. And even you might be knowing that our Prime Minister has given vaccine to other 8 to 10 countries totally free of charge. So we could make it. And for that, our basically Serum Institute of India is responsible. They gave a vaccine in a very cheap cost. So we could manage it.
Yeah.
Otherwise,
And
our vaccine.
Please continue.
Otherwise, we have vaccinated now in crores. That means the thousands of millions people are now vaccinated in India. And we are happy that this was done by our Prime Minister or our health department. And it has reached to the remotest remote place. That is another wonder of the of our country, that remotest remote place, people that A&M workers, ASHA or Anganwadi workers, they went there with the vaccination van and they vaccinated there also. So that was actually magic to all of us.
Such an important thing, and I had watched as India took polio vaccination out to remote areas as well, because I'm heavily involved in Rotary International, and the success of reaching remote areas was something to really be admired. And but the focus there was so much on children, and I think it's much harder to convince governments and supporters to support vaccination of older people. I see that we have a question from my colleague Adrian Tapatu, who is the chair of the Indigenous Working Group of the World Federation of Public Health Associations. And I think we're directed really at you. Can you see that question? Or will I read it?
No, I've got it. So I think it is a feature of the vaccination program in Aotearoa, New Zealand, that tribal groups organised essentially a new channel of vaccination services to meet the needs of our people in all of the areas where we live. So, the traditional routes of delivering vaccination through primary care and through some limited secondary care weren't going to get the kind of result that we needed. And so tribes, took the sovereign action of organising vaccination workers and trained people to become lay vaccinators and organise the supply chain to be able to get that service done in effectively every tribal community, from the very far north to the east, to the west and to the south. And because of that, I think we're now seeing an exercising of our sovereign rights in the same way that says, and what else should we get done that hasn't been done well by the system? And let's also check, what about other treatments for diabetes and all these other things? So it's actually become a rallying intervention for us to exercise more control in more parts of the health system. But it certainly came off the health crisis that COVID is.
And Ines and Nuria, I hope I pronounced your name correctly. I wonder, looking at how New Zealanders, Indigenous people in New Zealand, are organised for themselves, are there lessons for you in terms of working even more closely with immigrants, refugees, and the vulnerable people with whom you work?
Okay, for us, the most important thing is to be close to the community, to be available and to make things easier. I think this is the most important. And then for us, to improve the vaccination, for us, the key is to make the things available, to make things easy and free of charge, and to try to explain why we are doing that. Because in the first moment, when we see the migrants, now they feel healthy in general, and they do not understand what the preventive measures, because the objectives are different. They want to have a job, to have a house, and all these vaccinates, the blood status, all these things, they do not understand. I think we have to make an effort to try to explain why it's important. And then for us, the figure of the community health workers is important, because they feel healthy in the beginning. And then the preventive measures are not so accept in the beginning. They do not think about that. Do you want to?
Yeah, and look, you raise a really, really important issue about the fundamentals of health, you know, housing, work, nutrition. These are all such important things, even though we know how important vaccine is. We also understand why people have other priorities. And the question, of course, that comes up, and it has come up here, is around vaccine hesitancy. So that's part of it, but accurate information and fake information has been a really important challenge for us as well. And Vinod, I presume that's similar in India. Is that the same case for you? Vinod, there you go. We've got you now.
This is related to vaccine hesitancy. Yeah. Initially, people were more hesitant to take the vaccine because they were afraid that we might get reactions. So we had to do a lot of counseling. As such, in few of our villages in Pune city, we started our counseling center. And because of that, with the help of Public Health Foundation of India, and we were successful and making the vaccination program very much successful. Almost 80-90, more than 90% people from these villages, they took the vaccination, and few of them, they are out of town, so they couldn't do it. But the hesitancy initially was 100% there. But then people they needed, and therefore I think what is important is counseling and awareness, and telling them and convincing them that nothing will happen. And actually, therefore, health promotion is the most important thing, and that we did it during this.
Do we need to take that lesson through to human papillomavirus, to varicella, to pneumococcal, and make sure that we're doing the health promotion with regard to those in terms of vulnerable groups? Coming back to you, Vinod.
Yeah, actually, health we did through a lot of media and with the help of many stakeholders. So even doctors and then specialists in the community, with those who are specialists, neurologists, and everybody gave their lectures on the media, some paper articles in the newspapers, and then everybody insisted that now we must get vaccinated. And along with that, we trained our all health workers and paramedical health workers, including these ANM and all, and ASHA workers. Basically, we have ASHA workers in the remote places, and they did really hard work to make these vaccination programs successful. So ultimately, what we needed is convince the people that come to the center, take the vaccination, and those who cannot come, we will come there vaccination. So our government is almost successful in giving vaccination to more than 65% people. At least in elders, we got first and second dose almost up to 80% senior citizens, elders. And this is helpful in future vaccine program. Now people are now convinced that because of vaccines, we are here now alive. So when we started giving this pneumococcal vaccination, when advising them pneumococcal or basically H1N1 vaccination, this came forward and they took the vaccine. So that is the main success of this vaccination program.
There's an irony in this, isn't there, that COVID caused so much problem on the one hand, but also opened doors on the other hand, because your research at BRAC University, has it showing a similar thing in Bangladesh?
Especially the COVID vaccine hesitancy. Yeah,
Yes.
at the beginning, actually, there's hesitancy. I feel that, it's the Bangladeshi people are more or less deceptive, but the social media, because we do have access so much to fake information, that actually get a lot of misunderstanding among common people that, this vaccine is no good, it contains only water, and this and that is so funny things that you can't even imagine that this information common people are saying. But as I said, that at the beginning we have vaccine flow was slow. So more or less, I think that there was time for the government and the media to convince people. And Bangladesh has also very good infrastructure of government, NGOs, and private sectors working together. That's, some countries may not have, but we have so many NGOs in this country. So the government work, frontline workers, NGO workers, they all work together, and there are so many volunteers to serve the community. So I think that from all the countries, we are getting the stories that the role of the community frontline health workers so important, and that actually brought success to Bangladesh, I think, especially for the reducing the hesitancy around taking COVID vaccine.
And it is a good opportunity for us to acknowledge those frontline health workers and those who are delivering the vaccines, because particularly in the early stages, they didn't know how dangerous it was for them themselves. And they still were out there, yes, wearing their PPE, but and taking care, but also they still took those risks and delivered the vaccine and did so much other work. And in behind the scenes, epidemiologists and pathologists who were running all that work. So it's a good opportunity to recognise them. But for me, the challenge is still one in terms of influencing governments about elderly people and the vaccines that by and large are low. So in my own jurisdiction within Australia, it was about 90%, over 90% of people had more than 2 doses of COVID vaccine. In my own jurisdiction, it was actually nearly 99% had at least 2 doses. But we haven't bounced on from that and said, now we know how vulnerable elderly people are. Can we make sure that we reach them, and how do we reach them? I wonder, Nuria and Ines, if I can go to you first and answer for me if there's an effort going on within your own area in Catalonia and in Spain about this very thing, about how we're reaching elderly people for all these other vaccines that can be so helpful.
I think it's important to improve this coverage. And for us, regarding COVID, or we are talking about all the others? All the others, okay. I think in general, there are much effort to trying to talk about vaccines in adults. And then this is something that is quite new in the last year, more or less. I think there are a rising interest to talk about to improve the coverage in adult people. I think the COVID make us more aware of the necessity of these vaccines. And I think that our colleague was talking, Dr. Vinod was also talking about health promotion. I think that is important also to do health promotion among health professionals, because, okay, we are in an international unit, we are really prone to think about vaccination, but not in all the status of the institutes, think about health promotion and vaccines. And I think we need to talk more and to try to improve this information and to be aware of the health professionals, that each time that patients go to a health center, it's a good opportunity to vaccinate and to look about the vaccinated status of this person.
Thank you. And did you want to add anything, Ines, to that as well?
Talking about the health promotion, I think that unfortunately the COVID maybe made the population lose the trust in some health professionals in some way, in some way, because it was difficult for the population to go to the primary health units because they were not close, but there were more barriers to get into the health system. So I think another work that we need to do is to recover this trust and make people come to the health centers, and then try not to close again the primary health centers if another pandemic comes back. I don't know if it's going to come soon or in 5 or 10 years, who knows? But try to think about it.
And Nuria and Ines, thank you so much, because that input is really important. And you've added to the health promotion, you've also added trust. And I think that that's also a very, very important issue. So I will give you an opportunity after I've spoken to others to say any final thing that you would like to say. But as I go to each of the others, it's an opportunity for you to draw out any conclusions yourself, share your views, and then make a final statement. So I'm going to go to you, Dr. Roeri McCree-Jansen.
Yeah, look, I can close it out pretty quickly. I just wanted to notice, I think, what Dr. Afsana was telling us. And to be clear, COVID is not finished with us. We've got some distance to go on it yet, and it's partly because of what Dr. Afsana was saying, that globally we didn't act as a joined up human health system, and the rich nations serve their own interests first, and that's coming back to get us. And that means because we're going to have more variants, it's going to be around longer and it's going to be more complex. So I think it's really important that we do work across national boundaries and international jurisdictions to get to a better place. We've clearly got some of the solutions here with vaccination and with health promotion and prevention work. So really enjoyed being with you tonight. Kia ora, thank you very much.
And thank you for staying up so late. I know it's very late in New Zealand, so it's really, really appreciated. Vinod, would you like to share your thoughts?
Because of this COVID pandemic and this all vaccination programs, as we learned that lot of focus should be on the health promotion. And that is what we did, and building vaccination confidence in the people. Because of that, people started taking other vaccinations, and we had some problems here and there, like reactions to the vaccines. For example, one of our trustee of our foundation, he took the vaccine and he suddenly had some severe giddiness and vomiting, and he fainted and was admitted in the hospital. And then we investigated him for everything in detail, but we couldn't find out the cause. So our all even consultants and myself, we said that it is just a reaction. Next time when he wanted to take second vaccination, again the problem came, and he had similar problem. So now he said that I won't take booster never in my life. even if I'm awarded anything in my life, I will not go for this vaccination. So that this is what experience of my own trustee from our foundation. And then one of our doctor staying next to me in our colony, he also had very bad effect of the vaccine, and he got pulmonary thrombosis and we couldn't save him. So because of that, so these effects are always there all over the world. There it is noted. Hardly we see 0.5% of such effects all over, but they were in our state and our city, so people were afraid of. But in spite of that, we did a lot of health promotion through our government and other volunteers and other health workers and all. And we are almost successful in vaccinated this COVID vaccination. Not only that, but now, as I told, that people have started, in spite of having so many barriers and hesitancy for vaccination, people have now started asking for other vaccinations also. That's the success. So we do get some problems and complications, but they are noted all over the world. But most of the times we had success only. So that's the good thing.
Yeah, thanks so much, because you know we share. Of course, it's important to acknowledge these risks, but it's also important when we do a health promotion to acknowledge that the risk from vaccination is tiny, minuscule compared to the risk of the disease, and that message is the one that's sometimes challenging to get out to ordinary people. Dr. Afsana, you've been really forthcoming. I wonder if you'd like to conclude with any further suggestions.
I'm just thinking that we are actually in 2022, and SDGs by 2030 is not very far. And if you really would like to achieve SDG 3, I think we need to focus that how we can do a life course vaccination. And that life course vaccination should also be very thoughtful. So country context specific, that which vaccines are needed for those countries, not that every vaccines. That means the research, investment in research and innovation is very, very important. And I also feel at this end that global partnership, without global partnership, we may not be able to achieve SDGs for each country. We don't want to achieve, 1 or 2 countries. We really would like to achieve for everyone, so that no one will be left behind.
What a great way to conclude with the national, with the development goals, because I think that's the 2030 agenda. That's really where we have to maintain our broad health focus. So thank you very, very much for drawing that to our attention at this stage in the discussion. I want to thank each and every one of you for your insights and for sharing so openly in this discussion. I think it has been very, very helpful. Thank you to those people who put questions in. I hope we've answered them adequately as we have dealt with these things. In particular, thank you to the World Federation of Public Health Associations, to the University of Geneva, and to GSK, without whom this webinar would not have been possible. So thanks, everybody. I look forward to continuing this work and making sure that we get a normal part of life is vaccination across the life course. And with that, I draw this webinar to a close. Thank you very, very much. And thank you all those who have attended.